This is the Fix Your Sciatica podcast.
All right. And so we're back. Today we're going to be talking specifically about pain reprocessing therapy, PRT. You probably have come across this type of therapy out on the internet and also even just what you've seen on YouTube. And rather than just having me talk about the benefits, I thought it would be great to have a trained psychologist who actually is trained in this and also works with a lot of patients who deal with chronic pain. So today I have Deb Nelson, who was a guest probably about a year and a half ago, and she shared a little bit more about her chronic pain expertise. And she was really kind enough to share her expertise and understanding of PRT. So Deb, thank you so much and welcome back.
Thank you. Thank you. It's really nice to see you, and I so appreciate the work you're doing here. And I've been listening to your podcast, and I think all that you're covering just will dovetail nicely into what we're going to talk about today. So,
Well, thank you. The honor is all mine because I can go over the biomechanics and how the body moves. And I do have a pretty good understanding on chronic pain and overall the pain mechanism. But when people come to see me, they're expecting to move. They're expecting to do things with their body, which makes sense being a physical therapist. But it would behoove me and it would be a huge disservice if I didn't recognize that there are mechanisms that we cannot see that occur in our brain that helps us process pain appropriately, but also it's important for us to understand that when we have improper processing of those pain signals, it can be very challenging. And so well, first off, for the listeners who haven't listened to your first episode with us, can you just give us a quick little rundown about yourself and your background?
Sure, yeah. I've been specializing I'm a clinical psychologist. I've been specializing and working with chronic pain for about 15 years. Just as a side note, I find the work incredibly rewarding. And about 4 years ago, I got trained in pain reprocessing therapy. And at the time, I found it really interesting because what the creators of it put together wasn't necessarily brand new interventions, but what they did is they took bits and pieces of work from the field of pain management and from other psychological treatments and put it together in this very easy to describe and work with protocol. So since 2021, I've been including PRT in my work, and I've gone on to get additional training, and I'm certified at their highest level, their mastery level.
Yeah, well, so that means you certainly know a lot about it. So in your words, what is the core philosophy of pain reprocessing therapy? Because it's kind of like a buzzword. People are like, okay, I get it. I get that it's a thing and it's an effective, but like, what is it? And then tell us a little bit more about how that can actually differ from, say, traditional pain management.
Yeah, so traditional pain management has focused on, the work that people like yourself do, focus on medications, sometimes surgery, and then typically what we call cognitive behavioral therapy, which is looking at distorted thinking around pain, especially like catastrophic thinking. And the behavioral piece is trying to get people to move again and participate in life. And another important element or theory of chronic pain management in the field of psychology was working with acceptance and commitment therapy, which is just briefly kind of helping patients get to the point of accepting what is happening in their life and trying to figure out how to integrate it and move on according to their values. So that's just briefly. So with PRT, what we are bringing in is also important work of exposure response prevention, which comes from the field of treating phobias. And what we encourage people to do is to look at the pain, face the pain briefly, and then back out and kind of experience it in a titrated way, the way that we treat phobias. All of this is organized or designed to change the way the brain responds to the pain signal. That's the key of it. To go back a little bit, our brains are designed primarily to keep our body alive and functioning. 80% of the signaling in the brain is associated with just basic body functions. It's not to figure out what we should have for dinner or, the meaning of life. It's like, let's just keep this organism safe and functioning. Then we combine that with the fact that the pain signal, the way it works in our bodies and our brains, is that it's designed to create a sense of fear and a sense of urgency. And that's highly adaptive, right? We've been bitten by a snake, we stepped on a nail, we've broken a bone, our hands on a hot stove. The problem when we get to chronic pain is that we can't keep responding to that signal with a sense of fear and urgency. We'll quickly become depressed and anxious. And the fact is, because we've lived with that pain for some period of time, for some people over a decade, there's no need for a sense of fear or urgency. Right. So the essential nature of the work is to change the way the brain responds to the signal. So again, it's using traditional ideas like cognitive behavioral therapy, acceptance and commitment, exposure and response. And one of the pieces that I do think is particularly helpful about PRT is there's a big emphasis on patient education about how the brain and the body respond to and react to pain.
Thank you so much for sharing. Yeah, it really sheds light in regards to how much our brains are responsible for the pain that we feel. It's there as a way to protect us from getting killed, getting injured by the world around us. You brought up something very interesting, which I see this a lot. So very briefly, if you can, share with us how, say, something like catastrophic thinking can actually intensify the pain experience. Because as you were saying, like, the pain response, it's urgency, it's to protect us. But then also, it just spoke to me in regards to, like, what is catastrophic thinking? How does that translate on over into our pain response?
Right. So catastrophic thinking is in this category what psychologists like to call distorted thinking. And it represents thinking about imagining some kind of outcome or event that is very, very unlikely. So catastrophic thinking with sciatic pain might sound like, I'll never be able to walk again. I'll never be able to return to the work that I love doing. I won't be able to play with my grandchildren, whatever it is. That kind of thinking. It's very fatalistic. That kind of thinking is going to cause a huge amount of stress, which makes sense. We're going to have an emotional reaction to that. Part of what happens is there's a very physiological reaction when we experience that kind of stress, with the body releasing cytokines, which increases inflammation. So there's a very real physiological effect. But the psychological effect is a sense of anxiety and depression, and that will impact our ability to think clearly about what we need to do to help ourselves. And even if we're able to come up with something that can help ourselves, the depression and anxiety can freeze us. So that's part of it. And then the other piece of the puzzle, I realize I'm kind of jumping around a bit here, is and this is really important. I go over this over and over again with my patients. When we have some kind of injury in the body, the nerves are sending chemical messengers to the nervous system up into the spine and to the brain. And those are totally neutral signals. They're carrying messages, right? And those messages travel up the spinal cord and into the brain, and they hit the thalamus, which is a little structure in the midbrain, and it's like a relay station. So it distributes a signal to different parts of the brain. And this is really key, because what that means is the brain is interpreting that signal. It's not a direct one-to-one correlation. So because it's interpreting, there's a little bit of wiggle room here, right? Okay. Beyond the thalamus, one of the key pieces or key important parts of the brain that the signal lands in is the limbic system, which is the mood. Okay. So this is why the net effect of, if you're in a pretty good mood and you stub your toe, it's going to feel like a 5 out of 10. If you're stressed or angry and you stub your toe, it's going to feel like a 12 out of 10. So that limbic system is involved in your brain's interpretation of what's happening. So again, coming back around to the catastrophic thinking, it's going to have an effect on your limbic system, on your mood, right? And then your brain picks up that pain signal. It's like all of a sudden that sciatic pain has gone through the roof, even though structurally or physiologically nothing has changed.
Yeah,
Makes sense.
that makes perfect sense. And so what that means is it will, I will say oftentimes when I explain that to patients or when people hear that for the first time, they think, well, is it just me having to think more positively about my pain? And it's going to be more than just that. We're going to talk a little bit more about how to make that beyond that. And it's also important for us to recognize as therapists and clinicians that it's also from on behalf of us clinicians to the listeners and the patients that when we're sharing these pathways of pain, we are not dismissing your pain. We are actually recognizing your pain's existence, but that it may not necessarily be related to a specific structure and could be related to how your brain is perceiving them. So yes, in a way, pain is in our heads, but it truly is in our head because it gets processed in the brain, not because we're imagining it or not because you are imagining it. So, listeners, and Deb's probably saying the same thing where the pain that you experience is very real, but it is our jobs as clinicians from a physical therapy standpoint to help us really make sure if it's a structural thing, manage the structures. And then Deb's focus, which is going to be on the brain processing part of it, right? Now, before we get into the actual strategies, right? Let's talk a little bit more about how we as a community, both clinicians and patients, can start to whittle away the different or whittle down. Is the pain that I'm experiencing, is it related to some sort of structural or tissue issue with the tissues? Or is it the neuroplastic, the brain generated, the brain perception of pain? I'll share my stance after you share yours, Deb.
Yeah, sure. So often when I meet with people, I always ask them, what does your pain doc said? What does your PT say? Because it's important to have those perspectives from other medical professionals. And then I just sort of let people tell their pain story, which as a psychologist, the narrative, the words they choose, the structure, the facts they include, the facts they exclude is always really important information. But kind of more specifically, when did the pain appear? Was there a particular injury? What kind of treatment have they had? What's worked? What's not worked? When is it worse? When does it get better? And then also what else was going on in their lives when the pain appeared. So that kind of helps to get some background information. What I often see in my work, the vast majority of people I see, there was some kind of injury. For some, it was pretty dramatic. For some, it could have been a slight pull during a yoga class or something. But around that period of time was a huge stressor. And so this injury just never really completely healed the way it should have. And so these poor folks have gone to multiple medical professionals who are looking at the images and saying, there's something here. Maybe you pulled something, or maybe there was a tear, but it's not showing up in imaging. So it's a very kind of feeling of a mixed sort of experience. But kind of more specifically to answer your question, I can ask people did the symptoms appear without any injury to the area? And sometimes that's the case. Again, like I was saying, often there is often just subtle injury. The other big ones are that symptoms remain long after the injury is healed. The symptoms move from one body part to another without real clear explanation. Initially it was their shoulder, and that seems to have gotten better. Now their low back is bothering them and just kind of bounces around. Or another symptom that's really interesting is when people report injuries or symptoms or pain that are bilateral, right? And as you know, in your work, that's very odd to have that occur. And then another hallmark sign is if the symptoms tend to disappear when they're really fully engaged in an activity or doing something pleasant.
Yeah, really fascinating. I'm so glad you shared it because I think what I struggle with as a clinician is that I'll be seeing some of these patients who've been experiencing pain for years. And again, I myself as a biomechanist and a physical therapist, I'm like, okay, a large part of the pain that we experience is often due to pain. But one of the things that I look for, especially when it comes to managing patients, especially in sciatica, is number one, I have to, in order for me to provide an intervention, I need to find a pattern because the pattern of symptoms and the clinical presentation will help me understand what exercises or stretches or interventions are necessary. And this is what I take pride in is that we implement a strategy and action and we actually assess the immediate result of that. And this is where I think one of the big challenges is occurring in often the typical run of the mill physical therapy clinics where you go in and you're doing like 13 different exercises, but you're not even asked at each exercise, how does it feel? It's usually you go in, you do your 13 exercises, you tell the PT whether or not you feel good or better at the end of the session versus like after each one. So that's a big piece. But I find that usually in the absence of red flags, right? Making sure that the person doesn't have a cancer or fracture or tumor or anything that's happening within the spine. In the absence of those red flags and their pain doesn't present with any consistent pattern, I'm thinking, okay, well, maybe we're dealing with something a little bit more on I call it a sensitive nervous system, where the nervous system is interpreting these signals as pain, but it doesn't necessarily match a pattern from any sort of specific structure. The second category I look into is, can this pain actually be influenced by movement? And so if they're experiencing the pain 24/7 from the moment they open their eyes to the moment they close their eyes, and even throughout the day, and there's no change in regards to if they're standing, they're sitting, they're laying down, and they cannot find a position that is comfortable, I'm already starting to think, again, in the absence of red flags, that there could be, again, a sensitive nervous system. And then the third category, which it just occurred to me, it made me think, it popped up probably within the past couple months, is this recurrence of injuries and recurrence of flare-ups because of the fact that, well, there is research saying that if you injure an area, especially with sciatica pain, when you have sciatica pain at one point, there's going to be a high likelihood that you're going to have sciatica pain further down the road. And so and that's just the research says here's a scenario, but it doesn't necessarily say why. And so some people say, well, because you're having scar tissue or you're still having weakness. But I also think that there certainly is a neuromuscular or nervous system component that has an impact in regards to this recurrence of an injury, especially if it happens during around a specific event. So yeah, I'm glad that we were able to really kind of shed some light in regards to what you see and what I see. And so let's talk about the survival mechanism of pain, right? Really, again, pain is a way to protect ourselves. In essence, it's kind of like using fear, right? Let's talk about like how does the brain's danger evaluation system, aka our concept of fear, how can that get stuck in a loop where where the brain starts interpreting normal movement as a threat and presenting pain?
Right. What I would, I'm going to back up and give this a little bit of a thought because it's kind of complex. So, taking some of what we've talked about before, like the brain's primary objective is to keep us alive, right? Okay. To build on that, the brain, for a variety of reasons, tries to be as efficient as possible. And so it engages in this mental process that we call predictive processing. So it's looking for patterns and then it draws conclusions. And it does this across multiple domains in our lives, right? Okay. So what'll happen is, well, I'm going to lay three foundations here. There's the brain trying to keep us alive and functioning. There's its faulty processing using predictive processing. And then there's the experience of when our brain picks up pain, it creates a very physiological, scary, or at the minimum uncomfortable feeling, and then we have an emotional reaction to that. So it's kind of a double whammy. It's a double bad, right? So the brain doesn't want that to happen again. It's misinterpreting what's happening, and so it becomes highly protective. So, for example, the common example is if somebody injured themselves bending over and picking up something heavy, they go through the recovery, their back heals. it's very likely that every time they go to bend again, the brain's saying, oh, don't do that. Don't do that. And so that's where both of our work comes in, right? So I'm imagining, trying to help your patient understand that there is in fact safe movement through all of your getting them to test the movement and all of the explanation of what's happening in their body. And through my work, trying to share this information with them, this is how your brain and body are working, but try to reduce that overprotective, this is dangerous signal.
This episode is brought to you by the Patient Advocate Program. Are you tired of not having support between your rehab sessions? Introducing the Patient Advocate Program, and we're focused on your recovery, and we're offering you 24/7 access to a doctorate of physical therapy. Stop waiting in line to be seen and stop spending hours doing long exercise programs. Imagine being able to get all of your care delivered straight to your phone. Best of all, it's affordable. We believe everyone deserves top-notch relief without breaking the bank. So why wait? Take control of your health today and visit ptpatientadvocate.com and book your free call with our experts.
Yeah, that makes sense. Yeah, because like especially when I'm introducing movement to my patients, I would often say, listen, we are going to be doing these movements that might seem scary, but the goal is to introduce them in a safe manner. So we'll consider a safe manner as in low environmental stress, low fatigue. And I like to reduce the fear and make the exercise or movement more neutral. I will actually call it efficient movement. And so the way that I see it is that our bodies were actually designed to move. And the way that our bodies are designed, that is there's a route of movement that allows us to generate as much force with as little stress as possible. And so that's where the efficiency comes in. And when you are doing things efficiently, you can tolerate doing said activity for many repetitions for many times over. So when I describe those movements and even just showing people how you can integrate it while also minimizing the pain by shifting their attention. So like an example, when someone hurts their back when lifting something up, one of the first things I will teach them to do outside of the symptom mitigation tactics is to learn how to pick things up. But when I'm having them go through that specific movement, say it's called the deadlift, I'll say, all right, we're going to shift your hips back, but your attention should be focused specifically on your hamstrings. So in a way, it kind of distracts them from the potential pain in their back, but it gives them focus of being able to say, I'm going to use this. And so it's easy for me to be able to have them do it because they get a pretty immediate response. In some cases, when it comes to the nervous system processing part of it, it can take a little bit of time. And so for someone who's been living with this pain and listeners, remember, chronic pain is when you have crossed 12 weeks of experiencing said pain, because 12 weeks is the average length of time that tissue takes to heal. So when you're at that 12-week mark or beyond, the majority of the tissues in that area are healed to begin with. So we have transitioned into that stage where there is going to be something happening at the level of our brain. So to kind of go back, for someone who's been experiencing this for a long period of time, what are some strategies that they can do? And, we'll take an even deeper dive a little bit later in this episode, but like, how can someone who's been in pain for 10 plus years actually convince their brain that they are in fact safe, or what they're doing is safe, or that they're in a safe place?
Right. So this is where working with the therapist can be pretty helpful, to be honest, because the therapist can kind of ask some sort of challenging questions. And it's kind of sort of annoying to say and can be upsetting, but if people say, how can I be safe? I've been living with this for 10 years. Well, you've been living with it for 10 years, right? So what we have to look at is, how do we define safe? I try to get people to redefine safe, because for a lot of people, safe means no pain. So then we have to go into the education piece about, well, what kind of pain signals should we respond to? Should we be worried about? What kind of pain signals can we let go of and not worry about? So there's very much I guess it is a pretty cognitive kind of exercise, sort of challenging, again, the narratives that people are holding about pain and about safety. The other big piece of it is very akin to the work that you're doing in your PT sessions, which is, again, drawing on the ideas of exposure response prevention from treating phobias. So what that looks like in my work is encouraging patients to walk around the block. Just have to do it once. How'd that go? Well, you didn't like it, the pain flared, you got anxious, but you did it. So let's give it a day or two and you're going to do it again. And then we slowly get up to, okay, now you're going to walk around the block every day. So what we're doing is, again, what you're doing, we're retraining their nervous system. We're not overwhelming the nervous system, but we're retraining it like, oh, okay, this is safe. Because, again, it's going to be reactive, like, not safe, don't want to do this. And then simultaneously, we're breaking that narrative piece of, I can't walk. I can't be out in nature anymore. I can't be out in the world. So both those things are super important.
Yeah, absolutely. And so in addition to fear, I think from what I've observed is that our personalities can also influence the level of fear and the pain that we have. So in your line of work, do you find that there's a certain personality type, say like the perfectionist or like the people pleaser, who may have a tendency to be more prone to developing this type of nervous system sensitization? And if so, why is that the case?
Yeah, there's definitely some overlap. Well, to expand on that a little bit, in my work, the stats that I've seen is about 90% of chronic pain patients have some history of anxiety, depression, or trauma. So what we draw from that is that this is a nervous system that's been thrown on high alert. And I also make sure people really understand it's not their fault. It's not like their faulty thinking. It's life experiences or whatever's happened, who they are dispositionally, combined with a very stressful job they've had for 10 years. Whatever that might be. So that's what we really look at, is trying to treat the anxiety and the depression, because that's what's throwing off their nervous system. And as I mentioned earlier, and as I'm sure you know, when people are under high levels of stress, I mean, there's a real physiological reaction that's happening in their body that floods their nervous system with cortisol, the cytokines, their muscles tighten, their GI tract shuts down, and their brain starts spinning in usually catastrophic fashion. So, the other thing that I want to add here is that what I also see is that people who have high ACE scores, I don't know if you're familiar with the Adverse Childhood Events Assessment.
No, can you share? Yeah, talk about that.
Yeah, a little bit. It's, I think it was developed by Kaiser and another group. It's been around for, I want to say, 20 years. And it's a scale of assessing childhood events. Did your parents get divorced? Was there abuse? Did you move a lot? Was there a major illness? Did you live in an area of high crime? I mean, it's all these different factors that they look at. And what we know is that people who have high ACE scores very much tend to have chronic pain and chronic illness. And again, it's this whole idea of the nervous system has just been thrown into high alert. And then, so if your nervous system is already stressed and maxed out, and then you have an injury, right? You're just not going to be able to recover quite the same way. The injury, the recovery will be longer, the pain will be more significant. We also believe this is the mechanism behind central sensitization, that idea where pain spreads far beyond the area of wherever the injury occurred.
Before we go into a little bit more like the like some application of PRT, one question that did arise, because you did talk about like stress, trauma, like overwhelm, and especially me being a parent. And I can certainly see, especially like, well, before I had a child, I would observe parents as a third party. So I would kind of just see, all right, well, yeah, there is an uneven distribution of workload, but then also just kind of like the responsibilities of each parent. And so, a two-part question to this. One, from just like a general men versus women, do you see a percentage difference? And then also to follow up upon that, fathers versus mothers, and like what's that like in regards to the likelihood or the presentation of the pain distribution or chronic pain distribution amongst those populations?
That's an interesting question. I'm not sure I can answer it very scientifically. I mean, I can speak kind of more anecdotally. I will say I do believe that women experience more chronic pain than men. And the belief is there's physiological mechanisms behind that, and then also there's sociocultural mechanisms behind that. Now, all that being said, it is interesting in my practice, the men that I work with chronic pain often, not always, often have had a history of it being very difficult for them to express their emotions. So there is kind of this almost a sublimation process of that anxiety, distress that isn't allowed to be actively expressed. And also, if you're not, just as a sidebar, if you're not expressing your emotions, if you're not even allowing them to come to your awareness and then ask for what you need, you'll tend to get pretty depressed or anxious, right? So
That makes sense.
Yeah.
Yeah.
Hopefully that kind of answered your question.
It did. Yeah. It was just so interesting to see because, yeah, I mean, I think you really hit the nail on the head in regards to, I mean, you're only speaking on behalf of the distribution that you're seeing, but it kind of is representative where traditionally men, like, we don't really share what we go through, right? And so that stress kind of ends up piling internally, and it's a little different, yeah, amongst women as well. So it is good to know that there is a difference between the two. So let's talk a little bit more about like the expectations of PRT, because we were talking a lot more about like we know that it's this matter of like safe, these pain loops. Before we go into some like strategies behind it, let's talk about expectations, right? Is the goal of PRT, is it really more so to cope with the pain? Is it to eliminate the pain? Can the brain truly unlearn nerve pain, stuff like that?
The short answer to your question, last question, is yes. The brain can unlearn pain. When I start working with people around using PRT or actually any chronic pain work, I set the expectation that this is going to sound really counterintuitive. It's not about making the pain go away. It's about reclaiming important activities in your life. Because what happens, there's twofold. One of which is it would be really unethical for me to promise that I can make people's pain go away. I mean, there's too many variables involved. And two, what happens is when philosophically, emotionally approach the pain signals like you've got to go away, you've got to go away, you've got to go away, it inadvertently amplifies it because you're coming at it with this emotional energy, this anger. So the strategy is let's accept what we've got for today, for the near term. Doesn't mean forever. You're going to keep going to the doctor, keep taking medications, keep going to PT, keep hoping for a cure. But we're going to try to ignore it with the net result of that people reclaim important activities in their lives, their mood increases, and then their experience of pain is greatly improved, and in some cases goes away. So that's a much longer answer. It's more nuanced.
It's a great answer, and I really appreciate it. It's kind of like if you were to put a t-shirt on in the morning and you say, I'm not going to think about this t-shirt. I'm not going to think about this t-shirt. I'm not going to think about this t-shirt. The sensation of the t-shirt on your body is going to be very intense as compared to you put that t-shirt on, you go about your day. You have your t-shirt on, but it's not like occupying your mind, the majority of the time. So I really appreciate you sharing with that with us. So let's talk about flare-ups, right? Like the reality is the fact that when we do have injuries and when we are experiencing pain and the pain either dampens down or the pain goes away, there is going to be a possibility where the pain does come on, right? And we call them, we call them flare-ups. Some people call them false alarms. How do you coach people through those instances where like things do get more sensitive or like, yeah, I'm in more pain?
Yeah. That's such an important question. Often set out and tell people up front, like, this is going to happen. So, not to be a fatalist, but that's just life, right? You're going to have a big blow up at work, get an unexpected bill, decide to play pickleball and injure something, right? I mean, life's going to happen. So you'll have a flare up. It's super important how we talk to ourselves. And so the first thing that I advise people is to not label this as setback, because this is actually true. When the flare up calms down, which it will, you're not going to start back at the beginning of your pain recovery journey. You're just going to go back where you left off. So it's really a detour. It's not a setback. So do what you need to do. If that's rest, ice, take a break from your normal activities, trust that it'll calm, and then you'll get back on your path.
That makes sense. It's kind of, I really appreciate you setting the expectation that it will come back and that it will flare up because I'm going to use an example. When I see patients who have knee replacements are one of the most painful surgeries out there because usually they'll get their knee replaced. And listeners, what ends up happening is like they open up your knee and they put two pieces of metal on your body. And then in order for the surgeon to make sure that the knee joint is aligned, they literally play your leg like an accordion. So yeah, your leg is going to be pretty sore. But what's interesting is that within first 48 hours, you're feeling pretty decent. And the reason why you feel pretty decent is because the high level anesthesia is still running through your body. And so I've noticed the first part of my career when I would see these patients with the knee replacement, if I just went in and just started treating them, their most intense level of pain was from days 2 through 10. And it wasn't like, ouch, it hurts more. It's, oh my gosh, I think I need to go to the doctor. I think something is wrong type of pain. And so I started to experiment. Once I realized that trend, I started telling my patients on their first day of therapy, which I would see them maybe within 24 hours of them getting home. I would say, listen, between day 2 through 9 are going to be the worst. What was really interesting is that anecdotally, I think 90% of my patients who I told that they were going to get worse within the next week would tell me it was not as bad as what you told to me. It was real, and it was really comforting for them. So I did that inadvertently just because I said, well, why not do this? And it's exciting to know that you shared that with your patients too, which I really, really appreciate. And so in addition to like, yes, this will happen, I know for myself, I have a tendency to fixate on things. And so in some cases, when you are living in pain for such a long period of time, you're thinking about that pain all the time, 100 times a day. And I'll tell you what, I'm pretty guilty of it myself when I'm working with my patients because I do need that information from a test to retest standpoint. But I recognize that if I prod, if I poke, if I too much, the pain is going to intensify as a byproduct of me asking so much. So how do we find that balance or even just break that habit? Because in some cases, we do need that information to make decisions. We look at it from a period of curiosity, but at what point does that curiosity turn into something that's going to be more irritating than helpful?
Well, yeah. So, that which we focus on grows, right? So I do have, and it has happened in my work where I've had to encourage patients to change how often they're recording data for their doctors, their blood pressure or pain levels, especially with migraines. That tends to be something that people are tracking on a hour by hour basis. So there's that practical side of it, right? Is have a conversation with your provider about the minimal amount of data that you can provide. As a side note, the data that I look for is less about what would you rate your pain at today when I meet with people each week. It's rather, tell me about all the activities you did. It's like, Did you have lunch with friends? Did you follow through on our exercise plan? So it's focused more on what are you doing? What are you accomplishing, right? For those people who are focused, like constantly coming back to what's going on with their pain, part of what I think needs to happen is build what we call distress tolerance, because it almost is looping into like an OCD kind of behavior, right? There's this fear of their pain, and so there's a checking on it as if they're going to get some kind of relief, and maybe there's a temporary relief, but yet the pain persists. So it creates this cycle. So again, using kind of OCD models for building distress tolerance, if somebody's literally checking their pain levels 100 times a day, I would start with, let's check it 75 times a day. And those other 25 times when you're so distressed and you have this urge, what you want to do is you want to remind yourself that you're safe. We talked earlier about the importance of safety, right? And then also practically, you need to redirect your attention to another activity. And then the following week, maybe they check 70 times. Right. I mean, it's going back to the nervous system idea too, where they're just so amped and scared. So we're trying to calm the nerves and we're trying to break this narrative.
Yeah, that makes sense. So when it comes to breaking that narrative, right, let's talk about one action step that the listeners can take upon leaving this episode. So, for the many of us, we're going to have to pick something up from the floor. And so for the listener who was terrified about picking something up from the floor, what is the psychological safety signal or thing that they could do to send to themselves to make it seem less scary?
Yeah, so I don't have a short phrase or anything like that, but I think the big thing is reminding yourself of what you know about your body, right? What have you been told by the medical professionals? And the vast majority of people we see, their docs and PTs have said, it's safe for you to move, right? So take that knowledge in. You know that you've been told that it's safe that you can move. And then also remind yourself that pain, we can't always trust it, right? The pain signal can get stuck on the on position. It can be highly protective, okay? And it can be protective in ways that can actually cause more damage to us through pain avoidance behaviors, right? If we stop moving, then we're really in trouble, okay? So this kind of check, I've been told it's safe, right? I know that I can't always trust the pain signal. It can be faulty, right? I know that it's important for me. And then the last piece is the biomechanic piece, right? You really want to follow what you've been told by your PT in terms of how you pick something up off the floor. Be mindful about those movements.
100%, Deb. Thank you so much for shedding light on all this. I think it's important because, yeah, there's endless videos talking about how to do various different exercises, but I don't think there's enough action or information on the practical aspects of understanding that the pain that we do go through goes through our body, travels up our spinal cord, goes up into our brain, but then it's our brain that actually processes that information and tells us whether or not that is a safe or an unsafe signal. And so I'm really thankful for the work that you do, because there are certainly limits to what us physical therapists, like anyone who deals with body movement, there is a whole other part of it, which is the brain itself. So again, thank you so much for the work that you do. And in that, for the listeners out there who are like, I need to hear more from Deb, how can people learn more about your work and find more resources, and how could they get in touch if they have questions?
Thank you. Yeah, before I share that information, I want to say thank you for that nice wrap up, Ashley. And I also want to say that from my perspective, the work that you do is super important. The mind and the body are connected, right? The two very much need to work together. So the work that you do is equally as important as the work that I do in trying to help people recover from these sorts of, I want to call it health struggles, but life struggles, right? It really has a big impact on all areas of their existence. But thank you for allowing me to do a little shout out. So my website is drdebnelson.com, and I have a ton of information on my website. I send out a free monthly newsletter. You can sign up for it if you visit my website. If you'd like more information on pain reprocessing therapy, there's painreprocessingtherapy.com. There's a ton of information there. They have a list of directory of providers by state, so you can look for somebody in your area.
Awesome. There you have it, listeners. If you did not get a chance to write that down, I'm going to go ahead and put the link into the show notes. Deb, really eye-opening. Thank you so much. Yeah, listeners, go ahead and reach out to her because she is absolutely brilliant.
Thank you, Ashley. It's been wonderful spending time with you.
Thank you so much for tuning in. We hope you got some help from today's podcast. And for more info, check us out at ifixyoursciatica.com. Have a fantastic and pain-free day. No patient-therapist relationship is formed by listening to this podcast. We are not providing medical advice, and all information should be confirmed by a medical provider.